1 second, it is just going. Okay. Just a minute. Okay, so it is now being live streamed on YouTube. I'll go back to Zoom. So today we have as external faculty Dr. Mansi Munshi. She is a radiation oncologist at Ruby Hall Clinic and she has special interest in breast cancer. The team which is presenting. So it is now being live streamed on YouTube. I'll go back to Zoom. So today we have as external faculty Dr. Mansi Munshi. Sorry, on my system, the YouTube is also playing with that, latent period. So Dr. Mansi Munshi, who's the external expert faculty with interest in breast cancer, special interest. A team of residents from Tata Hospital would be presenting this case. Aditya, Akash, and Parth Sharma. And they will first present the case. Then in today's meeting, we will cover the loco-regional treatment because this is for early breast cancer. The systemic treatment, survivorship issues, and follow-up would be discussed in the next session next week. You can start, please.
Am I audible, sir?
Yes, you are.
Yes, sir. Okay. So good morning, everybody. Myself, Dr. Aditya Mittal, a junior resident 3 from Tata Memorial Hospital, Radiation Oncology. Today, I'm presenting my ward rounds on the topic of early breast cancer. So initially, I'll talk about the case capsule, and then we will talk about the loco-regional treatment. So I'll start with patient particulars and chief complaint. So 35-year-old lady, premenopausal lady, resident of Darjeeling, presented to us in month of September with the complaint of lump in left breast, incidentally detected 2 months ago, and there was some occasional pain over the lump since 2 weeks. So what was the history of present illness? Patient was apparently well 2 months ago when she incidentally noticed a small lump on the inner side of left breast. It was painless, approximately 1 centimeter dimensions. Lump gradually increased in size over the course of next 2 months. He has been having mild intermittent pain over the lump since last 2 weeks. The pain is comparable to a pin picking sensation, occurs with a frequency of 2 to 3 times in a week, and relieved on its own. She has been diagnosed with hypertension and diabetes mellitus and is under medical supervision for both. She has hypertension since 2003 and diabetes mellitus since 2017. So, just some relevant negative history. So, there was no history of any change in skin over the lump, no history of lump or swelling in the left axilla. There is no history of trauma to the breast, no history of discharge uh, from the area of nipple. There is no history of structural changes or retraction of the nipple. There is no history of significant weight loss in last 6 months. No history of any bony pain or backache in last 6 months, and there is no history of tingling sensation in the left arm.
So
So,
you have.
yes,
I'll
sir.
just interrupt. You have said about negative history. So what is the
Yes,
relevance of history of trauma? If you go back to your previous slide, yeah.
yes, sir. So, sir, there can be if there is trauma, so the pain can be due to trauma, first of all, and then there can be uh, there is a condition known as traumatic fat necrosis, which can happen in
Good.
breast.
Good,
Yeah.
good, good. And that can mimic like a cancer.
Yes, sir.
So the other question for you is, if suppose there's a discharge or bloody discharge from the nipple, does it mean locally advanced breast cancer?
No, sir.
No. Okay. So what is the condition which can give rise to discharge? We're not discussing the types of nipple discharge, but just generally, just tell me.
So, sir, one more one is invasive breast carcinoma. Second is duct papilloma can also
Okay. Okay.
present
Fair
at
enough.
yeah,
Okay. Carry on.
yeah. Yes, sir.
And Dr. Mansi, you can also ask any question if you whenever you want to.
Sure. I just wanted to add one thing here that in negative history, I know you'll probably cover it later, but relationship of the swelling with relation to her menstrual cycle,
That's very
that's a very
important.
important, extremely important. So maybe one line about that right in the beginning to
Yeah,
satisfy the examiners.
that's true. Because
Okay.
Yes.
initially you
Yes,
do
ma'am.
not know whether it is cancer or not. So that is an important point. Thank you, Mansi.
Yes, ma'am. Yes, ma'am. Okay, I've covered that thing in
Okay,
subsequent
carry
slide.
on.
Yes, yes, ma'am. Yes, sir. So I'll just talk about the personal history. So patient experiences no difficulty in urinary or defecation. Her appetite is unchanged. There is no dietary restrictions. She is experiencing normal daily sleep of 6 to 7 hours. Uh, she has a family income of 6,000. Lives in a kacha house in with bathroom facilities in a joint family. Completed a primary education up to the fourth standard and fluent in Nepali and Hindi. She is on tab amlodipine 5 mg OD and telmisartan 40 mg for her hypertension and tab metformin and glimepiride for diabetes. As I told, she is hypertensive since last 20 years and diabetic since 6 years. There is history of oral contraceptive use 7 years ago, which she used for a year and stopped. There is no history of allergic reaction to any food or medication. There is no past surgical history, no history of tuberculosis, no history of substance abuse, no family history of malignancy, no family history of any significant comorbidities. So, here I'll talk about the menstrual and obstetric history, which is important in the case of breast carcinoma. So, her menarche, she achieved menarche at the age of 12 years. She has, she is having regular uneventful menstrual cycle. Her LMP was, as we have seen the case in the month of October. At that time, her LMP was 15th of September 2023. She has one child which is doing well. There is no history of abortion or stillbirth. The child was delivered by full term normal vaginal delivery. Age at childbirth was 18 years. She breastfed her baby for 1.5 years. History of oral, there is history of oral contraceptive use 7 years ago, which she used for a year and stopped. Now I'll come on general examination. Patient was explained about the examination procedure and examined in a sitting position in a well-lit room under full privacy in presence of a chaperone after proper informed consent. She is a moderately built and well-nourished female. Her Karnofsky performance scale was 90. There was no pallor, no icterus, no cyanosis, edema or clubbing. There was no palpable cervical lymphadenopathy. Her vitals were stable. She was having pulse rate of 82 and normovolemic and BP at the time of when we recorded the BP was 130 by 90. And systemic examination was also within normal limits. So now we'll come to the local examination part. Patient was exposed up to waist with proper consent and examined in a sitting posture with arms by the side of the body. Uh, Raised. So we have examined her initially by when the arms were at the side of the body, then raised above head, and then pressed against the waist. And when the patient was bending forward. On inspection and palpation, no abnormality was detected in the right breast. So there was no visible difference in the contour, shape, and position of both breast and the nipple areolar complex. On digital palpation, there was a 3 by 2 by 2 centimeter single firm uneven swelling with irregular margins was noted in left lower inner quadrant at around 8 o'clock position, approximately 2 centimeter away from nipple areolar complex. The lump is fixed to the breast tissue. It exhibits slightly restricted mobility along the directions of pectoralis major when the patient presses her hands against the waist. The skin above the swelling does not show any warmth or discoloration. There is no evidence of podherans. There is no evidence of nipple retraction or discharge. Bilateral axilla was palpated for any lymph nodal swelling in the pectoral, brachial, subscapular, apical, and central lobe. There was no evidence of axillary or supraclavicular lymphadenopathy.
So you should always put a diagram when you're describing. I mean, the description is good, but a diagram, because we don't have a patient here in front of us. So a diagram always makes us understand better. In
Yeah,
future,
at the
when you present, please
yes,
add a diagram. Okay.
yeah, at
You
the time
should
of
have
summary,
known.
sir. Yes,
I know
yes.
it is
At
in the
the
summary, but
yeah.
otherwise
Okay,
I'm just listening.
okay,
Also,
okay.
Aditya, tenderness, always mention if it was tender.
Yeah.
So you can just say a
Okay.
non-tender
Yeah.
and then go
Yes.
ahead.
Okay.
Important.
Okay. So it's just a photo from SDAS, like how we palpate different group of axillary nodes uh, uh, at the time of palpation. So, and there are basically five, as we know, five lymph nodal groups in axillary when we do axillary examination. So, anterior, lateral, central, and supraclavicular group. These three group, anterior, lateral, and central group, we examine from the front, and posterior and supraclavicular group, we generally want to examine from the behind of the patient, and the patient is in sitting position. And these are the maneuvers which we perform at the time of examination uh, while examining all the different axillary stations.
So what is wrong with this group? What this photograph? What is wrong with this photograph?
Yes,
With all due respect to S. Das, can you tell us, please? Or any
um,
other residents want to speak? What is wrong with this photograph? The patient's identity is shown, the face, the
yes,
eyes
sir.
have not been closed. So, she may be someone's mother, grandmother, sister, or she herself may not, when this picture would have been taken many, many years ago, this, even if she gives consent for that. So, it is very easy to conceal the identity. There is no need for us to see her face and eyes and expression.
Yes.
Okay. So, please
Yes.
remember that, okay, thank you.
Okay, sir. Yes. Mm.
Not your fault. It is already in public domain. So, but I'm saying in the book, the publisher and the author, editor.
Yes, sir. So moving forward, so what can be the differential diagnosis based on our history and physical examination? So first differential diagnosis would be breast carcinoma. It can be fibroadenoma. It can be fibrocystic disease, or can be chronic mastitis or duct papilloma. But our uh, main suspicion will be breast carcinoma.
So, why you have put carcinoma over fibroadenoma in this lady? And so, if you can just in one line, you can tell.
So, sir, it was fixed to the breast tissue. So the suspicion would be more towards breast carcinoma, as fibroadenoma is a mobile swelling. Secondly, age will be in this case it can be both breast carcinoma and fibroadenoma because she's a young lady, 35-year-old,
Okay.
but fix
Okay.
it to the skin will be there. Yeah, yes,
And a cold abscess could always be one of your differentials down in the list.
Yeah.
yes. Okay. There was no inflammatory signs, so yeah,
No, that's what she had cold abscess. So, I mean,
cold lips. Yeah, it's a cold. Yeah,
always
okay.
see
Okay.
inflammation.
Yeah,
Okay.
okay. Yes, yes. So just to show how different.
See, all of you, because you are working in cancer hospitals, so your first thing is if suppose you are in a general surgery department of a medical college and a lady comes with this sort of finding, you may not necessarily put carcinoma as the first thing. I mean, you will obviously think at it when you consider it, but it may not be necessarily carcinoma. There you would
Yes,
think in a wider this thing, what all possibilities.
yes, sir, yes. So just to show that how different skin changes can look and how it can change our staging in breast. So just to show how dimpling, puckering, poderans, and satellite nodule on skin looks. So dimpling and puckering will not change our staging because in that case, in dimpling, there is involvement of Cooper's ligament, which can be due to it does not signify the involvement of skin, and same in case of puckering also it does not signify that there is involvement of skin. But in the case of Poderans, there is obstruction of intradermal lymphatics, and if there is Poderans, we will stage it as T4B. At it means that in cases of Poderans that there is involvement of skin, and if there is satellite nodule on skin, uh, it will also change the staging to T4B. So, what are the general investigations in this case? So we ordered a
It
hemogram.
said metastasis to skin. Maybe it is written like that in the Manipal book of surgery, but it's not
Yes,
metastasis to skin. It
yes, sir.
involves skin is involved.
Involvement of skin. Yes, sir. Okay. So what are the general investigations in which we order in this case? So it will be complete blood panel, which includes CBC, electrolyte panel, serology, blood grouping, liver and renal function test, coagulation profile, fasting and postprandial blood glucose that the lady is diabetic, serum HbA1c, chest X-ray, ECG, 2D echogram. So now I'll talk about the investigations of this lady. So there was a irregular high density heterogeneous enhancing mass with speculated margins was noted in lower inner quadrant of the left breast with few faint microcalcification and architectural distortion. So on USG correlation, a irregular hypoechoic mass of dimension 2 into 1.1 into 1.5 centimeter was noted in lower inner quadrant, 8 o'clock, around 8 o'clock. There was an indeterminate sub-centimeter left axillary node, asymmetric density of lower outer quadrant of right breast, likely parenchymal changes. The said lesions in the lower inner quadrant of left breast is reported at ACR BIRADS 4C, indicating a high suspicion for malignancy. So, just to talk about BIRADS score here. So, BIRADS, full form of BIRADS is breast imaging reporting and data system. So, there are 6 categories. So, 0 means we need additional imaging or prior examinations to this. 1 means it is the chances of likelihood of cancer is 0%. 2 means it is a benign swelling and the chances of cancer is 0%. If it is BIRADS 3, then it is probably benign. The likelihood of cancer is 0 to 2%. So we will request for a short interval follow, which will be for 6 months. 4 has 3 categories. So if we say that BIRADS, it is BIRADS 4, so there is some suspicion of cancer. So 4A means there is a low suspicion of malignancy, and the suspicion would be from somewhere between 2 to 10%. If it is 4B, it will be moderate suspicion, and suspicion would be 10 to 50%. If it is 4C, there is high suspicion of malignancy, which is more than 50%, but less than 95%. In all cases of BIRADS 4, we will request for a tissue diagnosis. If it is BIRADS 5, then it is highly suggestive of malignancy and the chances are more than 95%. And definitely we'll ask for a tissue diagnosis. BIRADS 6 means that there is surgical excision has been done and there is known biopsy proven cancer. So to show the mammogram of this lady, on our left, we can see left breast craniocaudal view in which there is lesion or calcification seen in the medial or the inner compartment, and on the right side we have a MLO view in which we can see there is a clump in the lower quadrant of the breast. So by this we can confirm our findings, and as there was a lesion in lower inner quadrant, and in the MLO and craniocaudal view we can see a lesion in the lower quadrant and in the inner quadrant of the breast.
Aditya, I'd like to just
Yes,
ask you a
yes,
question here.
yes.
Is there any, do we face any issues with mammography in young women? And if so, what is the reason for that?
So, ma'am, the breast tissue is dense in young women. So, it is sometimes difficult to differentiate and to see the lesion in mammogram of the young lady. So, maybe
You
we
say
can need
dense
a
means physical density or what density when you
yes,
say dense?
Yes, so basically the parenchyma is more dense, so it is difficult to differentiate the
Dense on
lesion.
imaging. It's not we're
Dense.
not talking of physical density,
Yes,
okay?
dense on imaging. Yes.
Radiologically more okay.
Yes.
And why is that?
Is there,
Just quickly. More
Yes.
of
More of sir, this
more of glandular
lobules.
tissue and less of
Yes.
fatty.
Less of fibers. Yes.
and is there any alternate imaging investigation that can help us in young women who are very suspicious for malignancy?
So we can definitely go for an MRI now.
Right.
But yeah,
Okay.
in mammography, we can do a contrast enhanced mammography that can aid to our diagnosis, or
Okay.
definitely we can do a
Very
US.
good. Okay,
Yes,
very good.
yes. So now I'll talk about the biopsy which was taken for this lady. So it was so our final histopathology report designated it as invasive breast carcinoma, NST grade 3, with modified RB score of 8. There was no ductal carcinoma in situ which was seen. It was estrogen receptor positive, 7 by 8, progesterone receptor positive, 8 by 8 all red score, and HER2 positive, which is 3 plus. So in subsequent slide, I'll just talk briefly about the all red score, as we grade our diagnosis of breast carcinoma by modified RB score, in which there are three components. We see the glandular or tubular differentiation, nuclear polymorphism, or mitotic count. So by all these three, we grade it as grade 1 tumors if the total score comes out to be 3 to 5. We grade it as grade 2 tumors if the total score is 6 to 7, and we grade it as 3 grade 3 tumors if the score is more than or equal to 8. As in this case, the score was 3 plus 3 plus 2, and it was grade 3 because the total score was 8.
So just before you move ahead, there's a question asked by Kartika Sherawat. Why not do just ultrasound in young women instead of MRI? So can you please answer this?
Sir, we definitely do ultrasound in this woman and in young women, but in ultrasound
Can
also we
ultrasound replace MRI? That
uh, no, sir, it can't. It cannot
why?
uh,
So
because
why
sir,
do they
in
complement each other, not a substitute?
sir, ultrasound definitely can help us, but if the tissue, like if the breast is uh, it has a lot of fat, so ultrasound also cannot like differentiate. And in cases of in special cases, we definitely need MRI as to differentiate if there is a multifocal or a multicentric lesion, or we suspect there are more than one lesion in our breast. So in that cases, MRI is definitely helpful, and to definitely see the breast, like soft tissue in the breast, we need an MR. But yeah, exactly, sir.
Which has greater specificity and sensitivity.
But MRI has a better uh, sensitivity. Definitely.
So I think, I mean, you have said few things not covered. So ultrasound is a good modality, not for screening or differentiating between breast cancer and other, for many other things, like for cystic lesion or other lesions, or the size of the lesion, or ultrasound guided biopsy. That's why we do. But it is cannot be substitute for MRI. Okay? For screening of breast cancer in small. The purpose of screening or early detection is that you pick up very early cancers, which you can't even feel. And if you are feeling a lump, then you want to characterize whether it is malignant or not malignant. That is the purpose. When you have a clinical suspicion that it's a fibroadenoma and all that, you just wanted to confirm your clinical suspicion of a benign lesion or a cystic lesion, then ultrasound can confirm that, can add to that. Okay, because in a very young patient, mammography will be suboptimal imaging because the breast is very dense. You will hardly see anything. Carry on.
Oh, okay. So just briefly, I will talk about the all red score. Uh, so as we have seen that in this case, we have designated it as 7 by 8 PR positive and 8 by 8 PR positive. So the Allred score combines the both proportion score and intensity score, and after that we get a score, and basically it's a histological score. So the amount of cells which are positive, about from that we get a proportion score, and then how intense the this thing intense they are getting the stain. By that we get a intensity score. So if it is after adding both of these scores, we get
Yeah.
a all-red score out of 8. And if it
Okay.
is the two scores are if the scores are of 0 to 2, they are considered as negative, and if the scores are 3 to 8, they are considered as positive. Yes. So, in cases of if this is just a small summary of how when we do ISC in cases of HER2 positive, HER2 testing, if the we generally do ISC in cases when it is equivocal. So why ISC? If we just see that how much the membrane are staining, if the membrane is faint, barely perceptible, then but within 10% of tumor cell, the ISC is 1 plus. If there is no staining of membrane and it is less than 10% of tumor cell, then ISC is 0 and termed as negative. If there is circumferential membrane staining, that is incomplete or weak and within more 10% of tumor cells, or there is complete circumferential staining that is intense but within 10% of tumor cells, then IHC 2 plus 4 is given, which is termed as equivocal, and then we have to do a fish for HER2 new amplification. And with the IHCs, if there is circumferential membrane staining that is complete, intense, and within more than 10% of tumor cells, then we'll say IHC is 3 positive, which is in this case. So this is how 0, a 1 plus equivocal staining and a 3 plus staining looks like. So I'll just talk about the different definitions of subtypes of breast. So luminal A is there are basically four classifications: luminal A, luminal B, and basal light, which is triple negative. So luminal A is ER and PR positive, HER2 negative, and the Ki67 score is less than 14%. Luminal B is divided into two groups, which is luminal B, HER2 negative, which is ER and PR positive, HER2 negative, but the Ki67 is more than 14%. Then second luminal B is luminal B, which is HER2 positive. So ER, PR, and HER2 positive, and the Ki67 score can be more than 14% or less than 14%. And the third subtype is triple negative, which is ER, PR, and HER2 negative. So in this case, the summary would be she is a 35-year-old premenopausal diabetic and hypertensive lady with a low lump in the lower inner quadrant of left breast, gradually progressing in size for last 2 months without any axillary swelling or nipple discharge or interaction. Local examination showed that there is a lesion in lower inner quadrant at 8 o'clock position. Size is 3 by 2 by 2 centimeter, and there is indeterminate subcentimetric axillary lymph node. Biopsy was performed to confirm the diagnosis. Here is a clinical diagram for this patient, and our diagnosis would be invasive breast carcinoma, NST grade 3, MRBS score 8. It is 7 ER positive, 8 PR positive, and HER2 3 positive, and stage would be CT2 N0 M0. And my plan for this patient would be I will like to do neoadjuvant 12 cycles of paclitaxel trastuzumab followed by breast conservation surgery with sentinel lymph node biopsy or axillary sampling, followed by adjuvant chemotherapy and followed by adjuvant EBRT along with uh, in adjuvant setting hormonal therapy and targeted HER2 therapy for at least 1 year.
So, Aditya, just to complete the academic discussion, you'll almost always be asked in the exam about FNAC versus core biopsy.
Yeah.
So that will be a whole discussion. Main
Yes.
reason is to obtain tissue for your IHCs, but also you should know the sensitivity, specificity, and the details of that. Secondly, is what is triple assessment in diagnosing a breast lump, and what is the sensitivity and specificity of triple assessment? These two things.
Yes, ma'am. So triple assessment is clinical plus radiological plus pathological diagnosis. So these are three which we are calling triple. So clinical followed by not followed by. So these are the three components of triple assessment in breast. So sensitivity will be like the highest for the pathological diagnosis, and clinically like
No, so
sensitivity
you
as
can
in.
just say that for triple assessment, there's a upwards of 95% sensitivity and specificity for malignant lumps, and almost 100% sensitivity and specificity for benign tumors.
Okay.
That's true.
Okay.
And someone has asked, what is the right time to mention metastatic workup and its finding in a case presentation?
Yes. So, sir, if there is any like metastatic workup, so if there is any clinical suspicion that if there is component of bony pain, or there is any clinical suspicion that there can be a metastatic disease, so then we can go ahead with things like CECT scan to further uh, do the radiological investigation, and uh, things like ELP and serum calcium to see if there is any metastatic disease or not. Or if indicated, we can do a PET scan also. But that is generally for this case, it is a early breast cancer, and the lump is 3 cross 3, 2 cross 2 centimeter, and there is no clinical suspicion of metastatic disease. So we will not go ahead with the uh, metastatic workup.
Carry on, we won't finish otherwise.
Okay.
I think when we will discuss locally advanced breast cancer, there will be a detailed discussion on metastatic workup. So I think in interest of time today, we are not discussing it more.
Okay. Yes. Just briefly to show the staging. So as we all know, a T1 tumor is T1 can be divided. Sir, should I discuss it in?
So I don't think we need to go into the
Yes.
details of the staging. Okay, I
Yes,
mean,
sir.
the slide is there, everyone will read, and you
Yes.
can go through.
Okay.
Next.
Yes.
So this is
So,
T and end stage,
and this
and
is pathology.
anatomic stage grouping, then
Yes, sir.
prognostic group.
Yes, sir.
Okay, so different hospitals, some hospitals do not use these groups, early breast cancer and locally advanced breast cancer, whereas some hospitals, like in Tata Hospital, we continue to use it. We also write, but I think T, N, and M, all of you have to use it, whether then subsequently you describe it, further or not. So that is important.
Yes, sir.
And again, locally advanced, T3 tumor could be operable, but it is locally advanced. Okay. So there's another term, large operable breast cancer, but it is locally advanced. So anything which is more than T2 is locally advanced.
Yes. Just a brief about how I think I've discussed, but still just to complete the discussion. So initially we do bilateral mammogram and ultrasound, and in special situation as ma'am has discussed, we can, or sir has discussed, that we can go for MRI. Then we go ahead with a core biopsy. Then we confirm the diagnosis, and then biomarkers are done, which is ER, PR, and HER2 and Ki-67. And if there is then we for disease staging and final pathological assessment, uh, we do a minimal blood workup as we have seen, and systemic workup for surgical excision, and CT scan of chest or abdominal imaging, and a bone scan with positive. So basically, they have discussed that when we should go ahead with a CT scan in ESMO guidelines, they have mentioned if there are clinically positive axillary nodes, if the tumor is more than 5 centimeter, if the biology is aggressive, or if there are clinical signs, or there is any suspicion on laboratory investigations. Then we can go ahead with a CT scan of chest or abdominal imaging. Otherwise, these things are not indicated in a case of early breast cancer. Uh, this is just a summary of management of early breast carcinoma. This is taken from ESMO guidelines 2024. Now I'll just discuss about the loco-regional therapy in the cases of
Sorry,
early breast cancer.
go back to the previous slide. So what it shows,
Yes.
just the overall schema of things. So how
Yes,
it is
so
different, dividing breast cancers into
So
early breast
basically,
cancer.
yeah, so breast cancers are divided into 4 groups in this case. So it can be hormone receptor positive, which will give subsequently give endocrine therapy. Then it can be hormone receptor positive and HER2 negative. It can be HER2 positive and it can be a triple negative breast cancer. So yeah, so subsequently
Then
we'll discuss in
so this is because
detail
ESMO, so this decides your the systemic therapy that
systemic therapy. Yes,
which
sir.
we will discuss later in the next week. We will discuss systemic. Carry on.
Yes, sir. Yes, sir. Now loco-regional therapy will be discussed by Dr. Akash. So he will take over the
Good
discussion.
morning, everyone. Am I audible?
Yes,
You are
Akash.
audible, Akash. Yeah.
Yes, sir. Dr. Aditya, can I screen share?
Okay. So so he has to stop share screen. Then I will allow you to. One second, Akash. I'll make you co-host. Yeah. So this is your screen, Akash.
No, sir.
Okay. So, but the same set of slide you're using, na? So you can speak. You
Yeah,
can.
yes, sir.
Yeah. Yeah. So
Yeah.
you can speak. I think the same set of slide. You can just tell next slide, please.
Yeah. Okay, sir. So good morning. We'll be starting with Dr. Aditya. Can you have the previous slide? We'll start with the loco-regional therapy, in which we'll discuss addressing local mass and the axilla in surgical principles and radiotherapeutic principles. Then next week we will discuss the systemic therapy, in which we'll discuss in detail endocrine therapy, targeted therapy, and cytotoxic chemotherapy. So in surgical considerations, when we are treating early breast cancer, so it all started with extensive morbid surgeries when Halstead's the first concept of radical cure in breast cancer came with extensively morbid surgeries where both pectoralis major, pectoralis minor, and skin was removed. Healing was done by secondary intention, and more importantly, the philosophy behind it was permeation of lymphatics through fascial planes. So even if the surgical morbidity was very high with poor functional outcomes, this gave us the first hope of cure in a breast cancer case. This ultimately, the morbidity of the surgery was modified over the years with Patty and Dyson's modified radical mastectomy, in which the pectoralis major was preserved without any compromise on oncological outcomes. Then we moved on to Madden and Auchincloss's modified radical mastectomy, in which both the pectoralis muscles were preserved and axillary clearance was not compromised on. This is the version of MRM, the modified version of MRM that we practice nowadays, if indicated. There are a lot of other types of simple mastectomy, skin sparing mastectomy, nipple sparing mastectomies. These are all variants that are just attempting to reach an amicable balance between preservation of function and cosmesis whilst retaining oncological safety. So,
Yeah, good description. You could have just added a diagram. It would have been a very nice slide if you had added a little diagram. Carry on.
so yes, sir. So, in the era of cosmesis and conservation, we have moved on to the philosophy of breast conserving surgery, which is widely and broadly described into two parts, that is, quadrantectomy and wide local excision. Quadrantectomy involves excision of 2 to 3 centimeter of normal tissue around the tumor, plus the removal of a sufficiently large portion of the overlying skin and underlying fascia. While wide local excision or lumpectomy, which is the standard of care nowadays, this is called as complete local excision with clear histological margins with just a rim of normal breast tissue. So the concept of margins as of now is no ink on tumor. We don't need an excessive high level of margin around it because we'll immediately irradiate the breast after breast conserving surgery. So no ink on tumor has to be achieved, and that can be achieved by just one rim of normal breast tissue around the suspicious mass, around the periphery of the primary tumor, and that should be on all sides. So this is a standard of care in early breast cancer with favorable breast tumor ratio, of course. So what are the major advantages of breast conserving surgery over mastectomy? The primary one is obviously the acceptable cosmetic appearance in majority of women, the preservation of body image. There's obviously low levels of psychological and physical morbidity. In cases where in patients with large breasts, removal of an entire breast from one side often results in back pain and postural problems that eventually lead to reduced quality of life in the in long-term follow-ups. There's less anxiety and depression, increased sexual and self-esteem compared with mastectomy. Moving on. So the evidences in support of breast conserving surgery, which sort of ushered in the era of more and more conservation and less morbid surgeries. Veronese et al. In 2002 did this trial in which over 700 women were randomized to undergo radical mastectomy or breast conserving surgery, followed by radiotherapy to the ipsilateral mammary tissue. It demonstrated no difference in 20-year overall
Akash,
survival. Yes, sir.
Akash. In 2002, they published their 20-year results. Okay, it was these studies were conducted and published in 1980s and 90s.
Yes,
Okay, this was their
yes, sir.
20-year result. Okay.
Okay, sir. I'll modify. And Varanasi et al. In that trial, the breast conserving surgery that they opted for was quadrantectomy. However, in the EORTC 10801, uh, in their trial, they did lumpectomy and full axillary clearance for in the BCT arm, and they randomized total around 800 patients to BCT and MRM arms, and they also demonstrated a no difference in time to distant metastasis or overall survival. So, what are the contraindications of breast conserving surgery? The absolute ones involve diffuse, suspicious, or malignant appearing microcalcifications throughout the breast. If there are widespread tumors that cannot be incorporated, that cannot be taken out by a local excision of single region or a segment of breast by achieving negative margin and a satisfactory cosmetic result. So we are not being able to achieve the balance between cosmesis and oncological safety. So that becomes a contraindication. In cases of inflammatory breast cancer, even if neoadjuvant treatment has given a successful response, we don't opt for breast conservation. In cases of RT during pregnancy, it's one of the relative contraindications because mostly after in the second and third trimester of pregnancy, uh, there's a possibility of opting for breast conservation and RT post delivery. That is one of the options. In case there's a homozygous biallelic inactivation of the ataxia telangiectasia mutated gene, that is a category 2B evidence for absolute contraindication of breast conserving surgery. The relative contraindications include active connective tissue disease, which involves the skin, because in that case, radiotherapy is an issue. If there's a recurrence in a previously conserved breast or previous irradiation to the chest because of Hodgkin's lymphoma or any other cancers, in patients who have P53 mutation or Lee-Family syndrome, for which excess risk of second malignancy is there due to radiotherapy, and uh, and if there are germline mutations in the ATM. So moving
Hello,
on to
ATM heterozygous and homozygous makes a big difference.
yes, sir.
Homozygous or a biallelic mutation in ATM means the syndrome, ataxia telangiectasia, that you should
Yes,
never
sir.
ever give any kind of radiation. They would get horrible, very extensive reactions. For the heterozygous mutation in ATM gene or for P53, the data is not really that strong. So I mean, you take everything else into account and then decide. Okay.
Okay, sir. So currently we are seeing another shift towards not just breast conservation, but also a philosophy of oncoplastic breast surgery, in which the principles and philosophy are very much in line with plastic surgery principles, where achieving aesthetic restoration of the symmetrical and proportionate bilateral breasts is used. So if the tumor is located in the central, inner, or lower central quadrants, and greater than 20% of breast volume will need to be removed in order to achieve oncological safety. That is one of the recommendations for oncoplastic breast surgery. So this has to be exercised with caution in India because of the higher stage of presentation as a whole in our cohort of breast cancer patients. So we have to make sure that the documentation of the surgical procedure, exactly from where the tissue was taken, how the tissue was modified in order to fill up the the open tumor bed, all these needs to be documented very meticulously because this has paramount importance in our delineation of tumor bed for our target for boost eventually when we are going for radiotherapy. So the types of reconstructions that we opt for in breast surgery, there are two major reconstructive techniques. One is the use of implants, another is the use of myocutaneous tissue flaps. So as a whole, implants as a whole provide a minimal prolongation of hospitalization or recovery. It has low cost. However, when we are using tissue flaps from the patient, it has natural contour with autogenous tissue, and it gives a very low risk of this thing. Flap loss, or in cases where there's a large or ptotic breast, it is indicated. So there are types of different reconstructive methods. So in cases of implant of tissue expander, what happens is if the skin is removed or in large ptotic breasts, there's a problem of poor symmetry, or there can be capsular contracture, leakage, and rupture eventually during follow-up, which causes multiple physician visits. And in cases of any a huge amount of anxiety in cases of any, if the patient has any symptoms for that. In myocutaneous tissue flaps, there are options of latissimus dorsi flap, transversus abdominis flap, deep inferior epigastric perforator flap, or there are superior gluteal artery perforator flaps. These are all natural contour flaps with autogenous tissue, and they all sort of the main disadvantage have mostly there's a donor site scar, which is a possibility. Flap loss is also a possibility, and mostly in the cases of where we are taking the tissue from, if it's a transversus abdominis flap, in that case there's a risk of abdominal wall weakness or hernia. In places where the flap loss is a possibility, there's a risk of fat necrosis also. In cases of DIEP flap or superior gluteal artery perforator flap, we need a microsurgeon to perform that, and that has a resource shortage issues in the bigger scheme of things. So, as a whole, flap reconstructions allow for more flexibility in the size and shape of the reconstructed breast. The long-term satisfaction with cosmetic outcomes tends to be higher with autologous reconstruction, although limited by the more extensive procedure and have risks such as donor side complications. Moving on, the local therapy of
Sorry to interrupt, but just wanted to
yes,
add
ma'am.
one thing here, that there's a surgery called as a therapeutic mammoplasty, which can be combined with a reduction mammoplasty. So, as a radiation oncologist, it's very important for us to know that women with very large size, ptotic breasts, which we find difficult to radiate without toxicity, this particular surgery can really help remove these folds in patients. So, you should know about this procedure: reduction mammoplasty and therapeutic mammoplasty.
Okay. So now the part where we are addressing the regional nodes from a surgical perspective. So axillary nodal burden is one of the most significant independent long-term prognostic indicator in breast cancer. There's 20 to 40% of patients with CA breast and clinically negative axilla, they have pathologic evidence of lymph nodal metastasis. So the types of surgery with which we can address lymph nodes of axilla are obviously the standard of care historically was axillary lymph nodal dissection, in which initially we addressed all level 1, 2, and 3. Eventually, the pattern shifted towards addressing level 1 and 2 in clinically negative axilla and level 3 in clinically node positive axilla. The issue with this surgery is there's high risk of lymphedema. Then there's poor functional outcomes in the term of shoulder dysfunction, then sensory motor loss in the upper arm. So eventually we shifted towards a more conservative approach where we went for sentinel lymph node biopsies. So what is SLNB? What we do is we inject technetium 99 metastable sulfur colloid, and just before the surgery we inject patent or vital blue dye. This is injected around the tumor and massage is done to facilitate lymphatic flow. Then a handheld gamma probe is used during OT, and this identifies the areas of highest radioisotope uptake in the lymphatic chain, which is compared with the antecubital fossa baseline radioactive uptake, and the places which we feel are basically a sentinel lymph node is like the first lymph node receiving lymphatic drainage from a primary. So when we understand that this area is the primary, the first uptake of lymphatics in that lymphatic chain, those lymph nodes, 1 or 2 lymph nodes, they are removed from that area and they are checked for metastatic involvement. So it has a high degree of sensitivity and specificity, which allows the sparing of morbidity that is associated with axillary lymph node dissection. However, obviously, if the axilla is clinically node positive, there's no point of doing a SLNB because we already know the lymph node that has been involved. So the evidences in support of SLNB as a alternative to complete axillary lymph nodal dissection came from the Almanac trial. They sort of checked the quality of life and arm functionality scores extensively, and they realized that in the sentinel lymph node biopsy arm, it was more than 1,000 patients were randomized, and they randomized to undergo sentinel lymph node biopsy or standard axillary surgery upfront. In case the sentinel lymph node biopsy came out as cancer positive, in that case, axillary clearance in a delayed fashion or axillary radiotherapy was decided according to the treating institution, the protocol. So they checked quality of life, arm functionality, shoulder function, and sensory motor symptoms in long-term follow-ups. And we realized that in the SLNV arm, this was significantly better. However, in the EcoShock Z11 trial, they checked the 10-year overall survival with sentinel lymph node biopsy alone and in axillary lymph node dissection, and they realized that it was non-inferior. There is no difference in 10-year OS or DFS. And this was the primary inclusion criteria in this EcoShock Z11 trial was T1 or T2 invasive primary breast cancer. They had no palpable axillary adenopathy, or and one or two sentinel lymph nodes were containing metastasis. So, moving on, this leads us to the next section of our loco-regional therapy,
Hello.
which,
Yeah.
yes, sir.
So I think today, because we don't have much time, so what we will discuss do is in the next 5-6 minutes discuss whatever so you all presented. Okay. So because radiotherapy itself is quite a lot of things to be discussed and presented, we will do it next week.
So,
And so the techniques and all, whether it's early breast cancer or locally advanced breast cancer, many techniques of radiation and fractionation would be same, except the indications and volume might change. So what you all presented in terms of the clinical presentation and how you take the history and present, that was fairly okay. I'll go to your initial surgical treatment and metastatic workup also. When we will discuss the locally advanced breast cancer, we will go in depth into what is, when you should do metastatic workup, what are the yield of different kinds of metastatic workup, how they complement each other, those aspects. In terms of surgery, you said the modified radical mastectomy, and you described different types of modified radical mastectomy. Doctor who started Halsted, he also probably knew that you could do
William
it.
Halsted.
In Halsted time, why did he do such a ghastly surgery? Can you think why he did that, and why Patey and Maiden could, and others, Auchincloss, could reduce the extent of surgery? What was the difference in the 40 or 50 years since Dr. Halsted was doing his surgery?
Sir, initially the concept was when the concept of cancer as a systemic disease was involving, Dr. Halsted's philosophy went into extensive local removal with removal of ribs, muscles, even
So
at
I think
times
what
in
you have to remember. So, but why did Patey and Auchincloss did not do that? First of all, they saw the morbidity of it.
morbidity, sir.
They were
Yes.
convinced that it can cure cancer, but it was morbidity. But remember, in 1880, 1890, when Dr. Halsted was, mastering his surgical skill on for breast cancer, most women would have presented with very locally advanced disease, which was involving either the skin or the muscle. So I
Yes,
think
sir.
for him, the typical patient that he saw, that the operation he devised for the typical patient he saw. In the next 40 or 50 years, there were many patients whose muscle or skin was not involved, or was not involved extensively. And plus, they realized what is the morbidity of this surgery. So you have to remember that it's not that Halsted, did not know that this will cause morbidity. But as you very rightly said, first evidence of cure, because some patients survive 10 years, 15 years, 20 years. Okay.
Yes, sir.
So that was one thing. Now, lymphedema rate. So that is one aspect. The second thing is you talked about the conservative surgery for the axilla. So what was the lymphedema rates with the axillary clearance. Any idea? Any one of you would like to say? See, whenever anyone does the change, why do you do the change? Why would someone move from a operation which works well, doing axillary clearance? So there was morbidity. One of the major morbidity was lymphedema. Would you
Yes,
like to guess what is
Sir,
the
it
around
was
20,
around 25 to
20 to
30%.
5, 20, 25% around in different trials.
Okay, so it was quite high. I'm talking of significant lymphedema, and that depended on how extensive surgery they did. Okay.
Yes,
Yes.
sir. And eventually it led to the another more serious uh, event where the entire arm was involved in different sort of skin, the Sever-Trevis syndrome, where that caused a discomfort uh, the patient's
So,
further life also.
so while surgery cured a lot of patients, they realized the morbidity, long-term morbidity of surgery. And when we'll talk about radiotherapy, what happens when we add radiotherapy to that? So maybe Mansi, in the next few minutes, you can talk about with them, discuss with them, bring out aspects of oncoplasty. He mentioned some different types of oncoplasty and reconstruction.
Yes, sir. So oncoplasty is, like he mentioned, it uses the principles of both oncological breast surgery as well as plastic surgery. And more breast surgeons are now trained in doing these plastic surgery like surgeries as well. So these are known as oncoplastic breast surgeons. And it is particularly useful for larger tumors and tumors where otherwise you would not have been able to do a breast conservation. So it mobilizes tissue from either the rest of the breast or from the surrounding tissues with a vascular supply. So there are various different types, and there are different ways of classifying oncoplastic surgeries depending on how much tissue is replaced or displaced. And you even have extreme oncoplasty, in which more than 20% of tissue may be displaced or replaced. Of course, it comes with a lot of there are higher rates of surgical complications with these procedures, including wound healing issues, including fat necrosis. For as far as radiation oncology is concerned, like you rightly mentioned, it can really pose a unique challenge for radiation and boost delineation. And that is why the very strict guidelines are laid down for the way the clips have to be placed in the cavity. A minimum of 6 clips is what is recommended. And this is very important because if you have a oncoplastic breast surgery done without clip placement, becomes virtually very difficult to delineate the boost cavity. Having said that, if an extreme oncoplasty is done with very wide margins, you have to also reevaluate the need for boost in such cases, because it's a very large volume and it may not even be necessary, especially in the era of chemotherapy and advanced targeted therapy and maintenance therapy. So,
Okay.
I think these
shall
are
I
very
stop at
important
that?
points.
Yes.
Yeah, so I think next week when you all present radiotherapy, so please show some of the plans which and how you have demarcated the tumor bed boost with the use of clips after oncoplasty. These days, so I think that's the more learning point, that what do you do, the clips that she mentioned, 6 clips, where they should be placed and how you contour. Initially we used to spend a lot of time with the surgeons till the time we figure out. Even now, many times you have to discuss with the surgeon and you have to call them on the planning system. So I think in the radiotherapy planning, practical aspects, you show them. Any other question from any other participant has, you can put in the chat box quickly. In a minute or two we can take. Otherwise, next week. No? Okay. So I think it's an hour now. It's 9:31. We'll end the meeting. It's a vast subject. We will, I think now then, next week cover radiotherapy as well as systemic therapy. We'll try to cover both if possible. Otherwise, the next week only radiotherapy for breast cancer, both early and advanced breast cancer. We won't sort of divide so whole entire radiotherapy. And the week after, it will be systemic therapy. Thank you very much. Thank you, Dr. Mansi, for coming and giving your expert comments. You may be remembering how we used to present rounds
Thank
earlier.
you. Yes, it's really nice to be a part of this and be a student again.
Thank you,
Okay.
ma'am.